So good evening, everybody. My name is Grant Besser. I'm the president of the Boulder Community Health Foundation. I would like to welcome all of our donors, volunteers, and many physicians who have joined us for tonight's second in our series of Elevate, which is a new series that the foundation started earlier in the month to really introduce topics that we feel are changing the future of healthcare. Today, I'm actually really eager for a thought-provoking conversation around what is happening both at the kind of national, local, and system level around the opioid epidemic. Very timely and relevant, especially in light of the uptick around addiction that we have seen since the beginning of the pandemic back in March. Unfortunately, a consequence, I think, of a lot of isolation that is happening, out there right now. So we got quite the panel that has been pulled together tonight that is going to give a lot of different perspectives about the crisis. But with that, I'd like to introduce our moderator, Dr. Elizabeth Cruse, who has been with BCH. We were debating whether it was 12 or 13 years. We'll figure that out by the end of the call. But she is our Ambulatory Medicine Department chair. She is also a board certified internist. A little background, she received her medical degree from Baylor College. She completed her residency at the University of Rochester in New York, and she received her undergraduate degree from Brown University. So pretty darn qualified to moderate for us tonight. So with that, I'm going to go on mute here in a second. Two quick housekeeping items. One, we do want to hear from you. So, throughout the session tonight, please be chatting in or using the Q&A function to submit your questions. And we'll leave about 20 minutes at the end to answer any questions from the panelists. If you're having technical issues of any kind, also please feel free to chat in and Paige will jump in to help. So anyway, sit back in the comfort of your homes, I hope, and enjoy the panel. I'll turn it over to Dr. Cruse.
Thanks a lot, Grant, and I really appreciate being asked to moderate this great panel. So thank you for joining us, like Grant said, and thank you for your support of BCH and the foundation. And I'm sure, like Grant mentioned, you're all aware that the use and abuse of both prescription and illicit drugs has really increased dramatically in recent years and has become a major public health concern, especially more recently with this pandemic and the isolation, as Grant mentioned. According to the CDC, the number of overdose deaths involving opioids, both prescription as well as illicit drugs, has more than quadrupled since the late 1990s. And across our nation, as well as our state and locally, there are many organizations that are working together to try to address the substance use crisis, as well as the underlying factors that contribute to substance use disorders. And today, we've really brought together several leaders in this area to let you know what's going on at all of these levels, what they're doing to help those struggling with opioid and other substance misuse. So what we plan to do is really discuss 4 topics. We plan to have some conversations about what's going on at the federal, state, and local levels, the work that is happening at BCH to provide resources and reduce stigma surrounding the epidemic, the action being taken by the Colorado Attorney General's office, and what alternative treatment pathways are available that address some of the barriers that exist because of the current public health crisis. So I'd really like to start too with introducing our panelists. First, we have Heidi Williams, who's the Director of the Opioid Response for the Office of the Attorney General. Heidi is a Colorado native and grew up in Brighton, Colorado. She and her husband, Toby, married in 2001 and have 3 children, Michael, Chloe, and Noah. Heidi is the Director of Opioid Response for the Colorado Attorney General and is the former mayor of Thornton. She's the co-founder of Food for Hope as well, which feeds hungry children and families. She also serves as the board president for Ralston House Child Advocacy Center and is on the board of directors for the Front Range Community College Foundation. She graduated summa cum laude with a bachelor's degree in political science in 2017 and earned her master's in public administration from CU Denver in 2018. We also have Danny Conroy, the co-founder of AIM House. He and his wife May opened AIM House in 1999. He started his career in counseling and activity leading in Boulder County's EXPAND program for emotionally challenged children. He is the founder of the CU Boulder Collegiate Recovery Center and was an advisor to the University of Colorado Center for Students in Recovery and runs Boulder Integrated Health as well. He is a regular participant and conference moderator for the university's annual Conference on World Affairs. He helped create the Cocoon program for chronically ill children at Children's Hospital in Denver. He volunteers his time with Horizons Elementary School, as well as Boulder County YMCA and other organizations. And certainly, last but not least, we have Amanda Roglewski, who is a licensed clinical social worker who has spent most of her career in HIV wraparound care and substance abuse treatment. She has worked with individuals, couples, families, and in pediatrics helping children and families with cardiac conditions. She came to BCH in 2019 to take the position as the program coordinator for our new opioid and chronic pain response program, which is soon to be called the PILLAR program, a grant-supported program for increasing education around, awareness of, and support for people and medical providers during this opioid epidemic. Amanda has been instrumental in growing and developing this program from scratch, working towards sustainability and serving the needs of our community. So I'd really like to thank our panelists for joining us tonight. So what I'd like to start off with is to let our listeners know what conversations are going on in the federal, state, and local levels. And I was wondering, Heidi, if you could start off by telling us what the state response has been to the opioid epidemic and what the Attorney General's office is doing to help support this effort. So thank you for starting us off.
Of course, absolutely. Thank you for having me. Well, first of all, I'd like to kind of tee up for everybody really what the opioid crisis is and how it's impacted Coloradans. So as most of us probably know, in the 1990s, we saw the Sackler family, the owners of Purdue Pharma, start over incentivizing doctors to overprescribe. And it turned into where a lot of doctors were either overprescribing or actually had pill mills where people were going and getting excessive amounts of opioids and, thus leading to addiction and often overdose deaths. So in Colorado, in the past decade, we've lost over 5,000 people just to prescription opioid overdose deaths. And then if you want to add another 2,000 to that number, which is really staggering, you can add in fentanyl and heroin. We know that about 80% of people who use heroin say they started out with prescription opioids. So the attorneys general around the United States entered into a multi-state lawsuit against Purdue Pharma in 2018. And then about a year ago, they amended that lawsuit to include the Sackler family to hold them responsible for, the really fraudulent and misleading marketing practices that they did that really led to this crisis. And so we have a couple of lawsuits going on, as well as some settlement negotiations. The first lawsuit is with Purdue Pharma, as I said. The second one, we actually just settled. It's through a bankruptcy court, but it's with Mallinckrodt. And so Colorado will start seeing money from that in the next year. We think the Purdue Pharma settlement will start seeing money from that within 1 to 2 years. But then the larger settlement that we're negotiating is with one large manufacturer, which is really Johnson & Johnson, but the manufacturer under Johnson & Johnson is called Janssen. And so that's the manufacturer. And then there's 3 large distributors as well. And so that lawsuit is going to bring in several $100 million to the state of Colorado over 18 years. So don't get too excited. When you bring something in over 18 years, unfortunately, some of that will feel a little diluted. But the money will be going to local governments and regions as well as the state. So it'll be kind of broken up into some different buckets. We'll be using that to work on our opioid response for the state. So one last really quick thing to mention is that I do work with a lot of local governments, treatment providers, and so on to make sure that I understand what the needs are around the state, because we do have a lot of different needs throughout the state.
Thanks. And so it sounds like there's a lot of, with the lawsuits and everything, a lot of funding perhaps coming in. So given that perhaps for the future, but what actions now is the Attorney General's office doing to address this opioid epidemic?
Yeah, so like I said, I'm going around the state, kind of talking to treatment providers. That's how I met Amanda. What's going on in your community? Tell me what the challenges are and the gaps that you're experiencing. The number one gap I always hear is supportive housing, right? That's not a surprise to anyone. But also really related to the criminal justice system. And so we're talking to communities about building relationships, starting these conversations about what you would use the money on. Where are your gaps? And then the state of Colorado, I believe, will help address some of these communities that have, like Alamosa, really hard hit, Los Alamos County, really hard hit with opioid overdose deaths and addiction, but very few resources and infrastructure. So as a state, we want to help figure out how to build that infrastructure up so these communities can respond appropriately.
I'm sure the COVID pandemic has really thrown a whole different level of barriers in there for people.
Yeah, especially, telehealth is great, but it's sometimes not enough for folks. And so we're starting to see that improve, but it really was bad at the very beginning.
Yeah. Thank you. Thank you very much. So for Amanda and Danny, can you highlight any collaboration that you have had with the state or perhaps at more of a local level? And whoever can unmute first goes.
Yeah. I can certainly piggyback off what Heidi said regarding the state level, and her and I have connected a few times and had discussions about the need and where the gaps exist. And yeah, just what she said, what would you do with the money? So kind of that magical question of if money were no object, right? Or if we had the resources at our disposal to address the underlying issues like she mentioned as well. And really get like creative around how we can make the dollars stretch and be as supportive as possible. And same thing at the local level, just talking about the needs we're seeing and how to fill the gaps with different agencies and different services. I'll let Danny jump in as well.
Yeah, first of all, thanks for having me. It's great to be here. I have not met Heidi, but I look forward to it at some point. Heidi would love to talk about the treatment gaps. I have lots of thoughts about that. I think people who are well resourced, we can create pathways for them. It's not that difficult. We can create pathways for them, whether it's through private detox or detox at the right place. They can write a check, have good insurance. It's not perfect, but the continuum's pretty good in their community. What we don't do, generally speaking, is communicate amongst ourselves as a continuum of recovery. And where I think our largest gaps are is at a community level. The programs that I've been part of, when they've been really successful, and the programs I've seen in other places, foster a sense of community that goes long beyond the acute level of treatment. And so what we know is that there's several different, in a perfect world, we're able to detox someone appropriately, which means medically assisted treatment at the right time. We're able to step them down into an appropriate level of outpatient care. We're able to address housing issues and perhaps vocational issues. All that's a long-winded way of saying that recovery is best treated, but with the mind, body, and spirits. We need to educate people as to what's going on. We need to treat their bodies appropriately with the right kind of nutritional counseling, make sure they're on the right types of medication, not the wrong types of medication, and be able to really create connection for them, right? Connection with other people, because when that happens, that's where we see that recovery blossom and grow. And we can't have funded program, we can't fund that for 15 years of recovery for somebody. So what we can do, though, is give them a really good start and create community programs, that really nurture that and then give back to one another. So there are gaps there, but it's very hopeful. We know what we need to do. We all just have to be able to talk together and then address what is the biggest issue, is funding and treatment gaps.
I forgot to unmute. I've only, just in the last couple of years, I've been involved, but I just wonder what your thoughts are, having been doing this for a long time. Do you see that collaboration improving, like organizations talking more to each other and coordinating better, or do you still see that probably there's still a lot of work to do, but just wondered if you would comment on that.
I've seen huge improvement. I've seen huge improvement in people talking with one another and connecting with one another. I think the improvement, that the next step of that is really collaborating on levels of care and collaboration of care from the very earliest stages all the way through extended outpatient, because really the process of it really looks like a year of treatment at varying levels of service along the way. But yes, for sure. And certainly like the collaboration we've been able to do with Amanda and learning about what's going on there. And the more that I talk to other outpatient clinics and all of us talking together, it's really gotten a lot better. We're talking a whole lot more. But we also need to be able to take some action in areas where these treatment gaps exist because people are dying at a pretty alarming rate. One other thing I just want to say really quick, and then I'm going to be quiet, is that the other thing that doesn't get represented is that there are about an estimated 22 million people in recovery from substance use disorders in the United States. That's a staggering number. That is a huge number of people that can show you that recovery is possible and that it can get better. And they're also our greatest resource in this situation in terms of collaborating and volunteer work and giving service to others. So just wanted to throw that in. Thank you.
So maybe just to tie on to that. So Danny, what are you seeing as far as the boots on the ground in the treatment world? I mean, what is sort of happening there? You sort of mentioned it.
Yeah, well, we're seeing a huge demand. I mean, COVID is like unfortunately, like putting a top on a boiling pot when it comes to people's mental health and substance use disorder issues. Isolation is one of the worst things that for us as recovering people, right? So not having the meetings, not having as much contact, not being able to hug, not being able to have group therapy in the ways that we've had them before, it's challenging. It's really, really difficult. That being said, I'm also really, really hopeful. I see people collaborating in ways that make more sense. As boots on the ground, the frustrating part is not being able to provide adequate, treatment to everybody because either insurance won't pay for it or there's no resources to do that. And, and you have to also, whether you're not for profit or for, you have to run your business. You have to pay your people who work for you and you pay them fairly and retain staff. So that's a big challenge. But what we're definitely seeing is a huge increase in the amount of emergency room visits, from what I'm told, the amount of people that are really seeking help. And the access to care hasn't gone up since pre-COVID. So you're going to see some compression, I think, as time goes on, which only to me really speaks to why we all need to be working together very closely to meet that need.
And just kind of back to the whole coordination, I don't know if Heidi or Amanda could comment on what you're seeing at your levels, kind of where Danny was talking about. Are you seeing better coordination between different organizations? Let's see if Heidi, you want to comment first, and then Amanda.
Sure. Yeah, I'm seeing a lot more coordination throughout the state, especially in regions. And one of the things that we're doing as the Attorney General's office is helping facilitate the different regions of the state to get together and determine which region they want to be in. So sometimes, like in the San Luis Valley, Larimer and Will County, and some other places, they're already doing this work. They already have built these coalitions. So they'll be ready and they'll have their plans together when money comes. There's other parts of the state that aren't doing that. But I will say that those coalitions that are working with law enforcement are seeing really great results because they're doing the law enforcement assisted diversion. Some of them are doing angel programs where people can self-refer to the police department without fear of getting put in jail. And so I think that working with law enforcement, working with the district attorney's office and treatment providers and elected officials and everybody getting together and just having these really hard conversations about who should be doing what really streamlines it and makes it a whole lot better for everybody once money does come in or funding or grants are available.
Great. And Amanda, how about you at the local level? What are you seeing?
Yeah, I would add that I do think it has improved. We were able to hit the ground running as a program and really start connecting with the community and across all the BCH service lines to create a continuum, like Danny had mentioned, and be a bridge between, if someone's seen in the emergency department or seen by their primary care provider and they are looking for more resources or needing more support, then we can help point them in the right direction. And we have about 100 community partners that will help us to find the right fit for people to reach their goals of care. And I also just want to say, I think it has a ripple effect as well, in that having these relationships with the BCH providers and with the community and all of us working together has the consequence, the positive consequence of opening the door for more people to feel okay or maybe accessing treatment, because we're also talking about a population that's pretty inherently distrustful of the medical system and law enforcement. So the benefits are almost innumerable for people, especially if that has been the barrier, that fear of being judged by a doctor or having to spend time in jail. So I have seen that too, just again, in the short time that our program has been in existence, working with law enforcement and different community partners has really been beneficial for us and for our participants.
Yeah, and that's kind of a great segue, I think, and Danny was kind of touching on it before, but Danny, how are your patients and how do patients, do you think, stay successful in their recovery? What do people need to know about that?
From my vantage point, it's community, community, community. It's about connecting with other people and having a group of people that understand you, that you can hang out with, that provide resources and networking with each other. And most of all, people to have fun with, people to be able to connect and that's the alternative. There's a great video that I encourage everybody to, I wish if I can remember, I'll put it into the chat, but it basically talks about that the opposite of addiction is not abstinence. The opposite of addiction is connection, and that connecting with one another. So there's so many issues that go into addiction, way more time than we have to talk about, but there's a hungry ghost element here. There's a very much something that's starving within people, and behind the drug addiction is usually a lot of stories of trauma, depression, undiagnosed mental health issues. It's a complicated web and it's a complicated picture. So the more we understand that, the better we can treat people primarily, but then it's connecting people to a community that really is everything. You can do all the other pieces, and then if you're not connected, it's very, very difficult to maintain anything like abstinence. The other thing I just want to mention really quickly is that we really don't talk about addiction the way that we do other either mental health issues or physical issues, and we tend to kind of polarize and push it off to the side, and we judge it just upon 100% abstinence oftentimes, or we look at it. Whereas you look at other diseases, you look at asthma, you look at diabetes, you look at heart disease, relapse is normal, and you have recurrence of use. You don't always have a relapse and someone's off the train. That doesn't erase 8 years of sobriety for somebody. We look at these things on such a myopic level when it comes to addiction because of the stigma thing that it's just a behavior choice, not a disease, and something that's more complicated than that. So I think it's just essential that we really look at it from a compassionate point of view, and that we really treat it like we would other types of disease. And that means education, the stuff Amanda's doing and crossing over and talking to docs and doing all these other pieces, because the more that we view it from that standpoint, the less shame that's involved. The less shame that's involved, the more people access care. The more people that access care, the better off we all are. So.
Right. Reducing that stigma in the community as well as among medical providers. Yeah, exactly.
100%.
So I think Danny set you up really well, Amanda, because my next question was going to be for you to tell everybody about how BCH is addressing the epidemic and what the Pillar program is now doing to help.
Yeah. BCH is addressing this at a number of different levels. It's very impressive, in my opinion, having worked for a number of different healthcare systems as well. And that is so much of what attracted me to BCH and to the position that I'm in now, is that it's a very tiered approach. And I'll start with our programming, and that's something they're doing, the existence of us, the Pillar program. So we, again, just provide service navigation, short-term case management, and some limited scholarship dollars to get people connected to treatment, either for some substance use disorders or alternatives to narcotics for pain, for chronic pain management. But that in and of itself is just, like you had mentioned earlier, Dr. Cruse, being part of the problem and now being part of the solution and addressing this issue from the inside out and within the healthcare system. So yeah, we're here, and we're a resource for, like I said, not only our participants, but so much for the medical staff and as the community when people are ready and when they need us. One of the other things that BCH has done is really encouraged a lot of the providers to get the DEA X waiver credential, which is so fabulous in breaking down barriers. And what the X waiver does is allow medical providers to prescribe a medication called Suboxone that has been really, really successful in helping people maintain sobriety from opioid use disorders. So we have about a dozen docs that are waivered that can provide Suboxone in a primary care setting. That's another thing, again, addressing it from the inside out and being part of the solution. And then even from an administrative level, our Med Management Council, they are really drilling down deep into the data of opioid prescribing across all of the service lines, the emergency department, the inpatient floors, outpatient prescribing, and looking at what are we doing and how do we change it? How do we create more responsible prescribing practices? How do we essentially change the culture around what it had been? Because like Heidi mentioned, for years, there were these predatory marketing practices done by the opioid companies, and changing the conversation around that change is hard and it takes time. So looking at how we can do that as an organization on multiple levels is really something that BCH has taken on beautifully, and, you know, taken on this fight, so to speak, against the opioid epidemic.
Thank you. Yeah, it's really exciting about all the stuff that's going on here to address the opioid epidemic. And I think we have time for one more question. This is kind of a big one, and I think maybe I'd like to hear from all of you what you think. What can we do as a society, do you think, just in general, to stop opioid use? And maybe go ahead and start with Heidi first, if you'd like to address that first.
Yeah, so, you know, one of the things that the Attorney General is very passionate about, and myself as well, is making sure that the settlement funds that come in don't get used inappropriately. If you remember the tobacco settlements and how those didn't necessarily get used appropriately. And so, number one, making sure we're using those funds for opioid abatement. And I think prevention education is a key piece of that. And so making sure that we're getting out and talking to our athletic directors at schools, our parents, our kids, our aging older adults, so that, you know, like National Take Back Day is, I think it's next Friday. And this is an opportunity, not just once a year, mind you. I just had a big foot surgery and had some opioids that I had to take because, you know, they're not always bad. As long as you take them responsibly and you know, have a doctor that's paying attention. But then once you're done with them, taking them back. I mean, I think everybody has some anxiety about not having them. And I assure you, if you need them, your doctor will prescribe them for you. So just take them to a take back day, to a take back bin. Walgreens and a lot of pharmacies have those. And there's also now some kits where you can dispose of them safely without putting them in the water system. I'm a former mayor, so please don't put them in your toilets because that goes in the water system. And then finally, I would concur with Danny, like we have to get rid of the stigma around opioid use. This is not about pulling yourself up by your bootstraps. This is about understanding that this is a disease that happens to your brain, and it really does take a long time to reverse those effects. So thanks so much for asking that question.
Danny, do you have anything to add?
Yeah, I mean, I think in our community, I'd really like to see a full medical detox. That's no secret to everybody who knows me. That's something that we've been talking about as a group, collaborating on. I'd love to continue talking about that post-COVID. Yeah, I think the early entry point is really, really important. It's sort of like there's a window of opportunity that happens post-overdose and, you know, during crisis admissions. And to be able to take that window of opportunity to get people detoxed appropriately and introduce them to levels of recovery is huge. And then, like I said about community on the other end, I think the more community you have, kind of like what we've had at the University of Colorado the last few years, it becomes a lot more about attraction than promotion. Like you start to see that stuff's happening out there and that the face of recovery is seen. And you see that it's not a life that's doomed. It's actually about, you know, feeling free and some other great stuff. So I see it as both. I see it sort of as promoting recovery more than focusing on the problem. I think we've come a long way with the way we prescribe. I'd actually argue, even as a person in recovery, I've been with my wife in the emergency room. It's hard, actually, even with a migraine. So people are really keen to it. It's not, you know, at least in our community, we have that. But But we got to make that on-ramp when people want to stop as easy as we can, to be able to treat them as quickly as we can. And I know we're all working hard to do that.
Right. And Amanda, I'll give you the last word.
Awesome. I would echo everything that Heidi and Danny said, and just add to the bigger picture component of, the destigmatization, of mental health and trauma, and making safe spaces to talk about it and to build those communities. And yeah, I like the way you said that, Danny, the on-ramp, making it as easy as possible for people to access care when they're ready and remove the barriers. So looking at things all along the continuum of addiction, mental health, and how the treatment looks. And yeah, again, prevention, education, and hope that recovery is so possible, and that the life of recovery is, such a gift, and people can get there, and none of this is hopeless.
Well, thank all of you very much, and I'm going to hand it back to Grant. I think we've really tried to focus on all the things that have been improved, but there's still a lot of work to do, and there's a lot of people working on it. So I'm going to hand it back to Grant for audience questions now.
Great. Dr. Cruse, thank you. And we are getting a lot of questions, and I encourage people to continue submitting them through the Q&A, and I'll try to get to all of them. So jumping in, you definitely have ignited some interesting conversations, and people want to go a little bit deeper on. Let's start with Heidi. So you were talking about the Sackler, through their role, on Purdue and accountability. We didn't talk tons about physician accountability and also pharmacy accountability, for that matter. Can you talk a little bit at the state level what's happening on that front?
Well, we do have our prescription drug monitoring program that is handled through DORA at the state. One thing that I would love to see a little bit of this money be spent on is to make that better. So it's really difficult right now for a prescriber to go in and pull up somebody's history. I guess it can take like 5 or 6 minutes just to pull it up, and then to start really drilling down if they see some flags. And it's also not mandatory. And so obviously that would take legislation, and I don't know if there's appetite for that. But, also I think that doing more prevention education with our physicians and our prescribers and our dispensers. And I was just talking with a doctor that teaches over at CU Med School, and they're actually doing a program with their students before they go out into their residencies, where they're hiring actors to come in and role play and really give them real life scenarios that they have to work through to help them understand what people in pain, or people who have who have an addiction to opioids or some other medication, are really going through, and how they might act. And so I think education is really important. But I do think that there is a certain group of prescribers that aren't really listening, and they've just been told the lie for so long that it's been hard to change them. And I think Amanda touched on that earlier. So yeah, we'd like to see a lot of work being done on that for sure.
Heidi, thanks. Dr. Cruse, as moderator, I'm going to put you on the spot here for a second. Didn't know that was coming, right? I've heard you mention before, it's like, physicians are part of the issue and need to be part of the solution. Can you maybe add a little bit, from a physician point of view to what Heidi shared?
Well, I think it comes from, I've been a physician now for over 20 years, and I would say grew up during that time where we were being told you treat the patient's pain until they say it's better. And a part of that it turns out it's an untruth about that opioids are safe and are not addicting. And that was actually based on nothing. It was based on a letter to the editor in New England Journal. I think back, and Heidi might remember better than me, like in the 1970s, and it wasn't even related to that, but the pharmaceutical companies took that little piece of information and marketed to all of us to make us believe that these medications were safe and they didn't have addiction potential, and we certainly found out that was not correct. So in a way, I think many of us have been unintentionally complicit because we were really trying to help our patients with the best information that we had at the time. But I think now, like every other science, medicine changes over time. We learn new things over time. And I think it's our responsibility to go with this new information and learn new skills and learn how to help people who may have a substance use disorder. Because as a primary care physician, I'm often the one who hears about this first. And I think receiving treatment in primary care often does help reduce some of that stigma. You don't have to go to a special place to get your care. You're in the waiting room with everyone else who's getting their blood pressure checked or coming in for their physical. So I think we do have a role here to play and a responsibility.
Thank you. Switching topics a little bit, maybe for Danny and Amanda here. Having 3 boys that are 16 to 21, this hits really close to home for me, and one of them being up at CU Boulder. And Danny, with your history at the Collegiate Recovery Program there, what does education look like, or what should it look like, in terms of really changing behavior at that level?
Amanda, you want to go first, or you want me to take it?
Yeah, I mean, certainly I've got a lot of thoughts. And, yeah, I can go first real quick, and then certainly I would love for you to elaborate more than I could. But I think for young people especially, education looks like honesty and being honest about having a relationship with substances, because alcohol is accessible, marijuana is accessible, illicit substances are accessible, and responsible use is definitely a thing. And, things can be enjoyed to a certain level. And even what Heidi was saying, opioids and painkillers have a time and a place. And again, what Dr. Cruse was saying, they are a good first line of defense, but then it's not the long-term solution. So again, like the honesty, the time and the place, just being open with young people and answering questions truthfully, and this abstinence only stuff has got to go. And being responsible is where I see the biggest impact.
Yeah, just to piggyback on that a little bit, I love what you said about honesty. Not all drugs are exactly equal. Not all drugs are going to kill you. There are ones that are much more likely to kill you, especially used with alcohol and other pieces. Students do listen to this. We hosted a Greek night on the campus, and we had 550 students show up in a panel conversation with other students in recovery. And I was shocked at how open everybody was. I was shocked anybody showed up. I was really, really, don't you miss being in a room with 500 people? I can't wait. But anyway, yeah, so people want to know. Students want to know. They just want to be told the truth. And from the time in the 80s when I was brought up, like I didn't know anybody on PCP who jumped through windows. I don't know why that's the only thing that they showed us. You're told that all these things would kill you. Everything's a gateway drug. And then kids experience some of those things for themselves. And they go, this absolutely is not true. So if that's not true, then maybe what they told me about opiates isn't true. And if it's not true, but so we just start to spin into this piece when our greatest single line of defense is telling people the truth.
I'll add to that, Danny, too. I grew up in the DARE era. That was very much everything was on the same playing field. And we know that's not true. So just to kind of further highlight your point of it's such a continuum and it's such a spectrum, and being honest with young people about that is truly the best line of defense.
There's a program now called Rise Above Colorado. I'm sure you guys have worked with Kent on some things, and they're really surveying kids to see how many kids are really doing drugs or experiencing vaping or whatever. And they're finding out that a lot of kids think the other kids are doing it, but they're not really. There's actually a lot less kids doing it. And so getting that message out too, instead of like, don't do it, like the DARE program is, most of your friends really are not. And so that's an important message as well.
Yeah, that's a great point. It is a fact that there's less illicit use among 17 to 23-year-olds right now than there was 10 years ago, 15 years ago, 20 years ago. So that's good news.
Danny, let's build upon that, and I'll throw this out to the group. What trends are we seeing right now? And really, maybe even the last 12 months, and especially with COVID, do we see things for opioid specific where it's shifting? Heidi, maybe start with you.
Well, I'm hearing kind of anecdotally about 30% increase. I'm sure that Danny and Amanda might have better stats, but it's definitely on the rise because of, isolation and people not having as good of access to their medication assisted treatment and their behavioral health stuff. So it's definitely concerning me and has since March.
Any others? Dr. Cruse, how about with your own practice?
Well, I think more we're seeing, and Amanda can jump in here, we are seeing people present to the ED, and, I think we're definitely seeing, I think in primary care, a huge uptick in anxiety and depression. That is something we do all the time, but I think, I saw patients the other day, and I think half of them is that's why they were coming to see me that day. So I think all the stress going on, the craziness that's going on is really taking a toll. And then like Danny and everyone else talked about, just that coupled with the isolation, you don't have your usual support, is just really hurting people. So.
And let's be honest, having your kids at home 24/7, for someone like me who's, was the mayor and I was busy and I was gone all the time, and now I'm home all the time with my kids. And, even just the thought of them not being in school 2 days a week, because we're hearing that, there could be some pullbacks into remote learning again, that creates anxiety for a lot of people. And it's hard on the kids and it's hard on the parents.
Yeah, I keep saying I'm so glad my kids have graduated high school. I'm a terrible, terrible teacher. I don't know how people are doing this at home. It is so tough. So
it's awful.
Yeah, it sounds like it.
Let me build off a point, Dr. Cruse, that you mentioned before about people presenting in the ED, and it's a question specifically for Amanda around medically assisted treatment, with Suboxone and Vivitrol, which you spoke about before. You spoke a little bit about stigma, right? And even with how physicians are viewing it. How do we actually increase access to MAT programs, and what will that take for physicians to come around?
I mean, not to sound like a broken record, but I think education is always the answer, because, these are people that are struggling. People are so much more than their use, and really getting that humanistic interaction is where medicine can leave off, right? And we have some providers that really, they're champions for MAT, and what I've seen, and Dr. Cruse, I think, can back me up on this, is that things land when it's coming from another provider. So when the medical providers are having these conversations with their colleagues about this type of work, they hear it, I think, a little louder than if it were to come from, me as a social worker, or the bedside nurses, or case management, or any of our other colleagues. So that is just what we try to do in all of our interactions. Shelby and I within our programming, and then again, I know Dr. Cruse is a champion for us as well, and provide the education in one-on-one interactions, or we do educational events that anybody and everybody is welcome to, now log into, that anybody was welcome to come to earlier in the year, but really highlighting just different facets of what not only this epidemic, but just what addiction looks like and entails. Again, something Danny said was treating it holistically and looking at the whole person, mind, body, and spirit, because that's what goes into an addiction. That's what an addiction affects, and that's what all needs to be fed on the road to recovery and throughout recovery.
And I would just like to jump, I think what Amanda's program, and then some of the other, in our system, and some of the other training programs we've taken part of through the Innovation at CU, I think is the name of the program, we got a lot of MAT training through, is that idea of harm reduction. And I think with some of us, it's just, well, I think with any of us, anything new or any change is difficult. Once it starts, it becomes routine. So like throughout the state and also at BCH, we're now offering MAT in the emergency department. When people present to the ED and say, I'm ready, we can get them started, and then Amanda and her partner Shelby can get them into a longer term treatment wherever that's appropriate for them. And then also the idea of having Narcan available if someone's not quite ready, they're not quite there yet, is to have that available and sort of teach our nurses and our physicians about that kind of harm reduction that can be very successful, keep people alive until they're ready to improve or to get better. Improve is a bad word.
So let me shift a little bit. Danny, you mentioned detox and the need for detox, in the community. One of our viewers today asked the question is, what are the success rates, after somebody going through detox? And I'll add something to that question of what do you think needs to be paired with detox to be successful?
Yeah, thank you for the question. It really all depends upon the continuum of treatment that comes with it, right? Like medical detox is a medical procedure depending upon what somebody's addicted to. And by the way, alcohol's still number one, everybody. Like alcohol and nicotine are still the kings, of this world. But alcohol, detox looks one way. Opioid detox looks another way. Benzos is the longest, that takes longer, right? So you buy yourself some time, you buy yourself some medical treatment and hopefully some good case management in order to make a plan for what it looks like when you get out of detox. Then, using MAT, medically assisted treatment, that has been mentioned, using cognitive behavioral therapy, outpatient services, individual therapy, we see by far the best success rates with those happening over the course of a year. Again, in a step down way, it doesn't mean someone's in treatment for an entire part of a year, but they're in a continuum of treatment for over the course of the year, infused with community involvement. That's where we're seeing success nationwide. That's why collegiate recovery programs have been so successful. So again, it's an on-ramp, but it's an on-ramp that's really important because just stopping that immediate revolving door, that first 24 hours, that first 48 hours, going to 72 hours is really, really key to kind of get a framework in line, get people just clean enough, get family members on board for what treatment looks like long term.
So what's been interesting for me, relatively new to healthcare the last 4 years now, is navigation. And there's a lot, if you look at behavioral health, right? There's just so many, different paths you can go down, and to be honest, probably a lot of rabbit holes that you can go down. For somebody who's worried about a loved one or a friend or a colleague, how do they help navigate that situation? And that's the magic question to all of you, whoever wants to jump in.
So I'm not a healthcare professional, but in my research and in my talking with people throughout the state, I think, if we can get our faith organizations and our community centers / organizations together to really do this boots on the ground community engagement in, number one, reducing stigma, and number two, making sure that there are recovery programs available for people who have gone through MAT and other types of therapy, because at some point they really just need to reintegrate or integrate into a new community so that they can stay on track. And, there's a lot of great programs that focus on getting healthy. So maybe a gym where, it's basically a gym where everybody, works on being sober. And there's a lot of programs out there that now are having more social events that are sober. So I think that, just really promoting that healthy lifestyle all the way throughout the community and getting rid of stigma. I'm going to say that over and over again. That's huge.
Yeah, and I know most of, and I say this about other treatment providers locally too. Those of us who've been doing this for a while realizes there's no such thing as competition. We're all out trying to save lives, make people's lives better. Reputable programs, a lot of them around us. I know Amanda and her team, and certainly if you call us at Boulder Integrated Help, we're going to try to find you help, whether it's with us or with somebody else. So we're going to go to every length that we can to try to get you the access to care. Can't always do that, and I'm being really honest. That's where it's tough. Sometimes the care doesn't exist exactly. The entry point doesn't exist exactly within what we have. So we need to keep working, and we have to all keep talking and create that. I think Boulder Community, I think the hospital is doing a fantastic job. The foundation is doing a fantastic job hosting this. And the one that we did a couple, is it 2 years ago? That was a great one too. And I know people were calling me all the time, just asking questions about their loved ones and would you recommend this or that? So talking, getting out there, hosting things like this, getting together in person, I think is really, really huge. And trying to increase, sober communities and, connecting young adults to, Collegiate Recovery Center, places like that, where there's existing communities already there that you can plug into is so huge.
Amanda, love to hear from you on this.
I was going to say, again, I'll just echo all of that. And I think the connection piece is a cornerstone of how we address the navigation and make it no wrong door, right? So anybody that is needing help at any time, like for example, in Longmont, their police force has what's called the Angel Initiative, where you can walk into the police department and say, I need treatment, I need help, and they're going to connect you with the case manager. Our program, just to get, kind of in like a little microcosm throughout the hospital system, and certainly like Danny was saying, in the community, there's no competition. If one of the providers, again, knows that their patient needs help, we know those questions to ask, because I don't know who mentioned the rabbit hole, but you can absolutely go down the rabbit hole. And it generally leads to a lot of frustration because of what Danny's saying of the point of entry, point of contact, financial barriers, time barriers, you name it. But if we can't find the answer, I'm going to call Danny. I'm going to call Harmony up in Estes. I'm going to call, one of the connections, Sandstone down in the Springs, and really try to find that right fit, because knowing this field and knowing these wonderful people that work in it, we know what questions to ask, and we know, generally where to direct, at least where to start. And having the case management component as well, like we're going to stay involved until we're done, until it's not appropriate. Somebody gets hooked into care, or, and I'll be honest too, people fall out of care. They're not ready. They're ready to maybe take a step and ask the question and do a little bit of the research, but then that's kind of that's where their ambivalence stops, and, it kicks in and they say, oh, no, I'm not ready for this yet. But we're still here. And all of us too, what we can do is plant seeds and continue to grow the community and the network.
Our vision at BCH is to partner to create and care for the healthiest community in the nation. I'd like to focus on partner for a second and do a quick whip around on everybody. Can you each talk about one organization that you think is doing a really great job out there around this? And selfishly, Danny, I'm gonna have you talk about Phoenix. I used to live next door to Scott, so I'm a fan. But yeah, may everybody do a quick little infomercial on a partner in the community that you are really proud of.
Well, yeah, you said it for me. Phoenix Multisports, Scott and those guys, they're heroes of mine. I love those guys. What they did and the way that they started was such a broad, way out there thinking idea, which is an active, sober community where people can rock climb together, ice climb together, go on long bike rides together. That's exactly the kind of thing that we see as glue, not just post-treatment, during treatment. They've been a great community partner with us, both at the Collegiate Recovery Center, at AIM House, at Boulder Integrated Health. Love Phoenix Multisport. Check them out.
Heidi, how about you? I think you're muted there. Yeah.
Yeah, sometimes my spacebar works, sometimes it doesn't. I've been really impressed with a lot of the hub and spoke models throughout the state. One of note would be run by Dr. Leslie Brooks, and I think it's Summit Stone is the hub, and it's in Larimer and Weld County, and they just are doing a really good job. They meet with a coalition of folks every single month. And again, they're working with law enforcement, the DA, the treatment providers, their RAIs and their MSOs. I know it's a lot of acronyms, but basically all the people involved in the healthcare system, and they're treating the whole person, which I think you all talk about a lot, is treating that whole person. And that's something that I can continue to think about as I'm looking at what can we use this money for, is how do we treat the whole person? Because treatment's not the only part of this, right? It's a whole continuum, making sure people have good case management and they're doing a really great job. So I would give them kudos.
Dr. Cruse, how about you?
I think I'm still, fairly new to this, and as a physician, I just really appreciate the sort of the teams that have built up around us. Because in addition to being a terrible teacher, I always joke that I was a terrible social worker. When you're by yourself and you don't know where to refer these patients, you don't know how to get them help, and in the midst of your busy day, it was impossible. But now we've built these teams, and I would call out specifically, really it's Boulder County Public Health is the one I've had the most experience with, their SWAG program, where they bring together all kinds of organizations across the county. And I have learned so much, not just even about opioid abuse, but also just about homelessness and organizations that help disadvantaged youth. And so just about all the people out there that are working incredibly hard to really help those who are disadvantaged on many levels. So I think we all get in our little bubbles, and that's really helped me get out of mine. So.
All right, Amanda, you're up.
There are so many. I've been running through names in my head the last couple minutes, and I'm going to talk fast because there's like half a dozen I want to shout out. But we worked the closest with the Denver Recovery Group, the Behavioral Health Group, and the Red Point Center. And those are all opioid treatment programs. And talking about the whole person, working with open space and mountain parks, they have a lot of focus on getting outside and getting in the natural world to help support recovery and mental health. And I felt remiss if I didn't call out SWAG, because the Substance Use Advisory Group, because it's a meeting of the minds. Truly, it's once a month we get together with, like Dr. Cruse said, so many different services, law enforcement, public health, housing, youth, BVSD, the Rotary Club. There's so many people that are a part of the SWAG that come together and share ideas and resources and really try to drive what treatment and holistic support looks like in Boulder County. Oh my gosh, there's one at the tip of my tongue that I'm forgetting. I'm sorry, people, I forget.
This is your Academy Award speech, and you just forgot.
It is, I know. And I'm getting the music. And
So, I think it's such a reinforcement of the power of the community around this in general. One that wasn't mentioned that I'll call out is City of Boulder, actually, through the Health Equity Fund. That was the original seed that enabled the pillar program at Boulder Community Health. And they've been really incredible partner, both from a funding point of view, but also helping us connect with others that are doing good work out there. I guess want to let all the panels know how much I appreciate everything that you're doing, but also the energy that you put into this conversation. We've had a really strong turnout tonight, and I think it's representative of how topical this is and how many people are looking for solutions. And I think your words are going to be very powerful for many. So thank you to Heidi and to Danny and to Amanda and to Dr. Cruse for your time. A big thanks to our donors, our volunteers, our physicians who joined us tonight. We appreciate everybody's time. We're actually going to be doing more Elevate education series. We are taking a slight break for the election to allow everyone to make their way through that. But you will see more from us, especially in 2021, as we'll be launching a robust series. So again, thanks to all of our participants, and I hope everybody has a good evening.
Thank you. Thank you, guys.
thank you so much.
Bye.
Bye.